Hi everyone, my name is Jed Homeloff and this is my presentation for Evidence-Based Clinical Practice, Assessment 2. So I'll start with the pathophysiology and epidemiology of the conditions that the selected client had. So osteoarthritis, or OA, is an idiopathic disease characterized by the degeneration of articular cartilage. Contributions from biomechanical and metabolic factors alter the tissue homeostasis of articular cartilage and subchondral bone, leading to an overproductive, destructive process which breaks down the cartilage matrix. The extracellular matrix interactions play a key role in the development of OA, which are mediated by integrins. Integrins modulate cell signaling, which is essential for regulating growth, differentiation, and maintaining cartilage homeostasis. OA causes abnormal integrin expression, which alters cell signaling and modifies cell synthesis, which results in the imbalance of destructive cytokines and overregulatory factors. Procatabolic cytokines activate the enzymatic degeneration of the cartilage matrix without the counterbalance of adequate synthesis of inhibitors, causing a reduction in cartilage within the joint. OA is the most common joint disorder, with evidence that the majority of those aged 65 years and over have clinical indicators of OA. The most commonly affected body parts are the spine, hip, knees, and hands. OA affects around 15% of the world's population and is predicted to increase in the coming years due to increasing prevalence of obesity and the aging population. So next is depression. Neurological imbalances have been accepted to underlie the pathophysiology of mood disorders, such as depression, although more recent studies have shown that structural alterations in response to stress contribute to mood disorders. It has also been found that exposure to stress causes alterations in the number and processes of neurons. Repeated stress is proven to cause atrophy of neurons in the hippocampus, whereas acute stress decreases the proliferation of cells within the hippocampus. It is evident that the depletion of the neurotransmitters serotonin, norepinephrine, or dopamine may be the underlying cause of depression, and the altered secretion of stress hormones such as cortisol contribute to the development of depression. Depression is a very common illness with more than 300 million people affected worldwide. It is the leading cause of disability worldwide and contributes majorly to the global burden of disease. Almost 800,000 people die to suicide each year, and suicide is the second leading cause of death for 15 to 29-year-olds. Fewer than half of those affected worldwide receive treatment, and females are affected more than males. Finally, we have hypertension. Despite intensive research on the topic, the pathophysiology of hypertension remains unclear, as only 5% of cases, or secondary hypertension, have a recognizable cause. For the remaining 95% of cases, known as primary or essential hypertension, there is no single clear identifiable cause, but rather it is likely that multiple interrelated factors cause the rise in blood pressure, and these factors may differ from one individual to the next. Possible factors that may contribute include salt intake, obesity, and insulin resistance, the renin-angiotensin system, and the sympathetic nervous system. Physiological mechanisms that may contribute to essential hypertension include altered cardiac output, increased peripheral resistance, reduced vasodilator reserve, increased stiffness of blood vessels, the renin-angiotensin-aldosterone system, and the autonomic nervous system. Hypertension affects 1 billion people and is the most common risk factor for death worldwide. It was predicted in 2012 that the prevalence of hypertension in males was 29.2%, and 24.8% in females. For men and women who are not hypertensive at 55 to 65 years old, it is estimated 90% of them will develop hypertension by the age of 80 to 85. Hypertension affects countries across the world in all income groups and was responsible for 12.8% of deaths in 2004 and accounts for 51% of cerebrovascular disease and 45% of ischemic heart disease deaths. So I have chosen a 52-year-old male client who was referred by physiotherapists to attend exercise physiology to address the main complaints of bilateral chronic shoulder pain and chronic low back pain. These issues were caused by severe degeneration and osteoarthritis in the shoulders and lumbar spine, which were developed after many years of manual labour working in a factory, which required manual handling of heavy loads and included movements such as lifting above the shoulders, twisting and bending. When assessing cardiovascular risk, hypertension was the only identified risk, which was currently being well managed with medications, and the additional condition identified during the assessment was depression. The client reported suffering from depression for the past 10 years and believed it was a result of his injuries, as they had prevented him from working, living a normal life, and participating in things he once enjoyed doing. The client reported previously seeing the physiotherapy department 1 year prior and completing hydrotherapy, which he found beneficial, but had failed to persist with due to financial hardship and other situations that arose in his personal life. When asked about his pain levels, the client reported aggravating factors for the shoulders to include lifting objects, moving his arms above his head, and overuse if he has had a busy day. For his lower back, the aggravating factors included any bending or twisting movements, lifting objects from the ground, and prolonged standing or walking. Reported easing factors included rest and the use of medications, which included Panadol Osteo, Nurofen, and Endone for when the pain gets really bad. The client noted experiencing pain on a daily basis at a level of 4 out of 10, but noted it could get to a 9 or 10 when aggravated, and therefore the client required Panadol Osteo on a daily basis and Endone about 1 day per week. This particular client was not currently completing any structured physical activity, as he believed he was unable to and was not confident to exercise on land as it would cause him too much pain. Hence he was adamant on a hydrotherapy program. He mentioned still completing incidental activities such as cleaning, gardening and shopping, although this had to be done mindfully to avoid aggravating his pain. He is not currently employed as a result of his injuries, so he relies on a disability pension. He currently lives alone as he is divorced from his wife, who he has a son with, but doesn't see him very often. The client also reported he is independent with all his ADLs and has no home assistance and is still able to drive. When asked about what he would like to achieve from the exercise program, he mentioned his goals were to manage his pain levels and reduce his reliance on pain medication. He also mentioned wanting to improve his function in terms of strength, fitness, and finding daily tasks easier to complete. Following the subjective assessment, some clinical measures were taken. Firstly, manual muscle testing of the shoulders was conducted. Both active and active resisted manual muscle testing was done for flexion, extension, abduction, internal rotation, and external rotation of the shoulder. It was quite consistent throughout each movement, as active range didn't differ between arms but was slightly limited by pain. When completing active resisted range for each movement, the client was unable to move through range with any resistance applied due to an increase in pain, and this felt as though he was holding back slightly as he was hesitant to cause pain. The only other objective measure completed was the pain disability questionnaire to get an understanding of the degree to which pain impacts upon this particular client's function in daily life. When interpreting the data, active range for each movement was below the normal range in terms of degrees, but was very similar when comparing each side. Therefore, no passive range of motion testing was required. Range seemed to be limited by pain and muscle weakness. The client was unable to move through full range of motion with any resistance applied for flexion and extension, so scored 2 out of 5 on the grading scale. The client was able to produce full range of motion against gravity for the remaining movements, so scored 3 out of 5. The client completed the pain disability questionnaire, which is used to assess functional status and disability through the patient's specific subjective experience of pain and how it affects their function in daily life. The following classification is used to examine the degree of disability. Mild to moderate disability is ranked from 0 to 70. Severe disability is from 71 to 100, and extreme disability is 101 to 150. The client returned a total score of 99 out of 150, which places him at the higher end in the severe disability category. At the completion of the exercise intervention, this tool will give a good overall picture of the client's view on how pain is affecting him and if any improvements have been made. This patient has multiple potential barriers to prevent the successful and effective treatment of his conditions. The first potential barrier is depression. The barriers of depression are well known, and include the patient's resistance to mental disorder diagnosis, not being ready to accept treatment, or failing to follow through on prescribed treatment modalities. Healthcare professionals often fail to prescribe an adequate treatment intervention or fail to follow up with patients once treatment has commenced. Also, inaccessibility of mental health professionals due to things such as location or socioeconomic status may present as a barrier. Men are also less likely to seek help for depression than women. In relation to this client, the most likely barriers would be failing to follow through with the treatment intervention and not having access to mental health professionals due to his low socioeconomic status. Chronic pain may present as a barrier as it has been shown to significantly affect quality of life in physical, psychological, spiritual and social domains. It is linked to anxiety, depression, loss of independence and interference with work and social relationships, which all may affect successful treatment. Worsening pain during exercise has also been associated to a barrier of adherence. It has also been shown that patients with chronic pain have a serious issue with adhering to home exercise programs, which is a key component of successful treatment of this client. Financial constraints and lack of social support have been identified as barriers to adhering to exercise treatment, which apply to this client as they are identified during the subjective assessment. This client is currently unemployed due to his injuries and relies on disability pension to survive, which he says is difficult. This is evident as he required a payment plan in order to afford the 8-week hydrotherapy program. The client also reported being divorced and living alone, which leaves him with limited social support, creating a barrier to effective treatment as he is solely self-reliant. This is my reference list, and thank you for listening.